Welcome to the We Got Softer Toilet Paper and Other Low-Cost Ways to Engage, Retain, and Recruit Staff conference call. My name is Rebecca, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Donna Thorson. Donna, you may begin.
Thank you, Rebecca. And welcome to everyone joining us today. I'm pleased to be able to host this webinar for you. I have worked with David Farrell for a couple of years and have really learned a great deal from him. And so I would like to take this opportunity to introduce him to you. He is a licensed nursing home administrator and has spent his entire career in the long-term care profession. He actually began as a certified nursing assistant so that he could earn money while he was going through college. And in the past 27 years, he served as a nursing home administrator and regional director of operations, really advocating for patient-centered care using quality improvement practices. You may have had the opportunity to read the book that he co-authored and published with other members of the Pioneer Network called Meeting the Leadership Challenge in Long-Term Care, What You Do Matters. And at this time, I'd like to turn it over to David Farrell. Thank you.
Thank you so much, Donna, and thanks to everybody for taking time out of your busy day to join this webinar. I'm going to jump right in here because we only have 1 hour. So, what matters most? What matters most to delivering consistent, high quality to the residents and patients within our facilities? What matters most? Is it the systems that you implement and sustain? Is it the physical environment and space that you create for people? Or is it your people themselves? That's the big question. And of course, the answer is complex and multifaceted, but for the purposes of the next hour, I want to argue that people matter most. And if people matter most, then you matter most, you being the leaders who are running these complex healthcare organizations. High-performing organizations in our sector of the healthcare continuum, they contain 3 very common elements according to the research published by Les Grant at the University of Minnesota. These high-performing organizations have been focused on implementing person-centered, individualized care for years. They push the envelope with innovation, and they do things now to get to know residents and patients as fast as they possibly can when they come in the door in order to avoid that unnecessary rehospitalization. High performers have a committed workforce. They have low absenteeism, they have low turnover, and they have high retention rates. And foundational to it all, they have leaders who engage in very specific evidence-based practices over and over and over again in order to retain their high performers and recruit high performers to their organization. The results that skilled nursing facilities get are highly interrelated. Those who implement person-centered care tend to boost morale, and when morale goes up, stability comes with it. Customer satisfaction is really dependent on workforce stability and employee satisfaction, and when you can achieve some of those foundational pieces around stability and satisfaction, consumers and customers and family members notice, and they tend to compliment the staff for the efforts that they're making, which leads to higher satisfaction and even more stability. When we can achieve those first 4 bullets, nursing homes tend to have better clinical outcomes, and as a result, they tend to have better regulatory compliance, and as a result of that, they tend to have better, higher occupancy rate and a better mix of clients in order to cover their expenses. Low-performing organizations in our field have just the opposite going on, and I unfortunately or fortunately have had a lot of experience trying to turn around very troubled, low-performing organizations. And it's been my experience that when I go in, I find these three common elements. These are organizations that have ignored any type of movement towards person-centered or individualized care. In other words, they're deeply committed to institutional, task-centered, harried, depersonalized care. And as a result, they have an unstable workforce. They have high turnover. They have low retention. And they usually have very high absenteeism. So a lot of instability. And unfortunately, low-performing organizations also have leaders who unfortunately are practicing and performing in such a way that they're creating the instability that we're trying to avoid. The vicious cycle of low-performing skilled nursing facilities tends to play out this way. Staff instability leads to a lot of stress on the organization, and usually a high number of DONs and administrators tend to come and go in these troubled low performers. It's not unusual for when you arrive as a new administrator for the staff to say that you're our fourth administrator in the last 7 months. There's always a lot of correcting and in-servicing going on in these organizations, but nothing ever really sticks because of the staff instability. There's lots of morale and poor attendance issues, and the end result is poor outcomes. And poor outcomes, unfortunately, in low performers tends to result in limited resources, fewer number of staff, fewer number of good supplies to give the staff. And it just creates, if you will, this vicious cycle that's so challenging to break. I want to share with you the experience I recently had in Oakland, California. I was working as a regional director and had about 11 skilled nursing facilities within my region, and we purchased a very, very troubled nursing home in Oakland, California. I'm sure it was cheap, relatively speaking, because when I walked in, it was nothing short of the worst nursing home that I had ever seen. And I was in absolute shock and awe when I arrived. It was in such bad condition that I decided that I needed to put my license on the wall as the administrator in the hopes that I could turn it around. But I have to admit that I was completely depressed after about 5 days of being in the facility and had serious regrets about hanging my own license on the wall there. Everywhere I looked, there was chaos and depression and broken items and ineligible forms. We had rats, we had roaches, we had small flying insect bugs all over the kitchen. There was nothing going well from my perspective, and it was a very troubling first week. And I can imagine that some of the administrators and directors of nurses on the phone can relate to how I felt that first week. When you walk into a situation like this, it's hard to know even where to begin. But years earlier, as Donna introduced me, she mentioned a book that I had penned with Barbara Frank and Kathy Brady called Leading the Leadership Challenge in Long-Term Care. And it was a book about trying to turn around another troubled inner-city nursing home that I was the administrator of a few years earlier. And so essentially what I did here is I reread sections of that book to remind myself of the specific changes that we made back then in the hopes that I could apply some of that learning and wisdom to my current situation. But I have to admit that the first Oakland nursing home was actually in better shape than the current facility that I was in. But I was reminded by reading that book that I had to build trust and make a statement. I had to be present on the units. It was a different world now, and I was getting 50 emails a day, but I needed to ignore the email and make my presence felt. As much as the chaos was so disturbing to me, I had to get out of my office and make my presence felt. I began to ask and try to deliver what I could to the staff, but of course they were rushing around in a harried state and barely had time to speak to me. In addition, I didn't look like any of them, and to them I was just another administrator passing through who likely wouldn't stay very long. But eventually I remembered a PM shift CNA asking if maybe we could go back to purchasing bendable straws. And I think you all know what bendable straws are. Those are those straws that you can actually bend compared to the straight straws. She said that a few months ago we switched to the straight straws in order to save money. And it was very difficult for her to help her clients and her patients consume liquid in bed with those straight straws. So she asked me, the new administrator, if there was any way we could get bendable straws. And I saw that as an opportunity. I rushed to CVS Pharmacy. I bought some bendable straws, and I got them back in the facility before dinner. And she was very impressed by that. It was this just-a-moment kind of delivery of showing her that I was listening to her and delivering what she needed. And it turns out that she was a fairly influential and smart and respected CNA of that community, and she told others of what I did, and they began to trust me as well. In addition, I knew I needed to be consistent. I knew I needed to listen, not just listen to people speaking in front of me, but eavesdrop, if you will, on the conversations that were happening around the nursing station, because there was a lot of stress there and a lot of raised voices, and I was trying to figure out what was going on. In addition, I began to speak with conviction about person-centered care, and I could tell by the reaction of the staff that they had never had an administrator actually speaking with conviction maybe about anything. But at every opportunity, I was speaking with conviction about higher quality, person-centered care, quality of life, and people were a little bit shocked by what they were hearing. But probably the most important thing that I did my second week on the job was I decided to paint the graffiti that was all over the building on my own. And we had graffiti inside and outside of this building in Oakland. And as most of you know, staff who are engaged in a lot of physical work, like our staff are, they deeply appreciate seeing administrators and directors of nurses doing some physical work themselves. And so I wanted to make sure that the staff could see me doing some physical work. So I had the maintenance guy set me up with the roller and the paint, and I went out to paint the graffiti in front of the building and just kind of let the CNAs that were there on day shift follow me out. Now, granted, they were mocking me as I was painting over the graffiti, reminding me that we were creating quite a nice canvas for the graffiti artists to come back that evening. But first and foremost, for me, it was just satisfying to paint over the graffiti and see some fruits of my labor, if you will. But most importantly, I knew that regardless of what they were saying about me, they were impressed that I was picking up the paintbrush myself and getting busy to try to change what I saw as a very chaotic environment. And what happened to me was it gave me hope. It reminded me that one single person, perhaps me, could infect that organization with person-centered care. I could be that patient X, if you will, that could infect it and change it forever. I was reminded by painting the graffiti that small changes matter. And it's not about the big bang theory when you're trying to turn around a troubled nursing home. It's really about 100 small, consistent changes, all pushing in the same direction towards person-centered care. But most of all, I was reminded that employees and residents and their families are deeply influenced by what we might conceive as very small things. Human beings within our centers are acutely aware and sensitive to the immediate context of their physical and social world, and administrators and directors of nurses who make changes can make changes that positively influence those relationships in that environment. And without a doubt, in this situation, that graffiti on the building was saying to the staff who walked in, nobody cares and nobody's watching. And until we painted the graffiti that was symbolic of the chaos, it was going to be very difficult to change what was happening on the inside of the building. I want to remind you right now that your impact is probably greater than you perceive. There's something about the organizational makeup of these fragile ecosystems we call nursing homes that make them particularly susceptible to poor leadership practices. However, because of their fragility, they're extremely responsive to leaders who are practicing the evidence base, who are focused on employee engagement, and who see that as a primary role and responsibility on their job. Your leaders, your actions influence the organizational culture, the health of the relationships within that culture. Your actions influence whether staff are engaged or not. And as a result, your actions influence quality of life and clinical outcomes. The best leaders in our profession can flat out go into a nursing home and get better performance from the people working there. However, the very best also can raise the level of humanity and compassion amongst the staff at the same time. And that's really what we're striving for. In Oakland, I had to lean heavily towards my compassion and showing staff my compassion before I could trigger their performance. And sometimes leaders have to recognize that. If you push too hard on performance without them feeling the compassion and seeing your compassion, the performance usually doesn't last. When I first started for the QIOs in California, way back in the early, 2001, I somehow came across this fascinating research study by Susan Eaton from Harvard University, and it was titled, What a Difference Management Makes. And Susan Eaton at that time was quite a pioneer because up until then, for the most part, me and my colleagues and researchers and even association leadership, we tended to blame our nursing home turnover issues on the employees themselves. We tended to lean towards reasons why our turnover was so high, and we would point to reasons that were outside of our control. Well, Susan Eaton questioned that. And so she did a research study whereby she wanted to figure out what the difference managers make between two facilities located right across the street from one another. So she found these unique situations of nursing homes right across the street from one another. And one would have very high turnover and the other one would have very low turnover. And she wanted to figure out why that could possibly be. Because, after all, if the problem of turnover lies in the employees themselves, wouldn't all nursing homes have a turnover issue? And what about those facilities that are recruiting from the same labor market, paying the same salaries, with the same benefit package? In those situations, how could we have a high degree of variability amongst turnover? So she paired them up, high and low, went on site, conducted 159 interviews, and she identified these specific areas that distinguished low turnover nursing homes from high turnover nursing homes. And she pointed out these specific five. She said, leadership visibility in low turnover nursing homes is very apparent. The administrators and DONs, they're out of their offices, they're out amongst the staff, they're communicating appropriately with the staff and professionally, and they're engaging with the staff. In the high turnover nursing homes, she noticed that the administrator and director of nurses tended to stay in their office. They had their office door open, but because they didn't build trust with the staff, staff would not go to them with questions or concerns. They said, we have an open door policy, people can come in, but people really didn't see it that way. The second one was that she noticed that in low turnover nursing homes, the leaders there showed through word and deed and practice and policy that they cared for the caregivers. She didn't see that in the high turnover nursing homes. In addition, in the low turnover homes, they had systematic ways to show that they cared for the caregivers. They had what they called individualized orientation in the low turnover homes. They had career ladders, and their scheduling practices were vastly different than the high turnover nursing homes. At that time, it was quite unique to find nursing homes that were utilizing consistent or primary assignments. After all, in 2001, all of us, including me, assumed that rotating staff assignment was best practice. What Eaton found was that in the low turnover nursing homes in this study, they all practiced consistent assignments. The high turnover homes were rotating staff assignments. And as a result, she noticed that in the low turnover homes, they just rarely worked understaffed, where in the high turnover homes, they always seemed to work understaffed. And she mapped out this vicious cycle of vacant shifts causing stress, which leads to turnover. And the uniqueness of this was that she basically identified the trigger of this chaos and this vicious cycle is not turnover itself, it was vacant shifts. Vacant shifts leads to rushed, harried, depersonalized care, which leads to a bad day for the staff and even a worse day for the residents and the families. For your steady Eddies who come to work every day, they just start to get resentful for being shifted around, giving more patients after their shift starts, etc. So they get burned out and stressed too. Stress in our environment leads to med errors, poor judgment, injuries, but most of all it leads to fractured relationships. It leads to people snapping at one another, which of course leads to people not talking to another once again. That leads to turnover, which perpetuates this vicious cycle. What I've noticed in troubled nursing homes, like the one I ran in Oakland, was that they're usually very good at retaining low performers, but they have a very difficult time retaining high performers. We know now through mountains of research that instability amongst staff, either caused by turnover or absenteeism, leads to poor outcomes. Why? Because it affects communication and continuity of care. Why? Because it leads staff to have to care for residents who they don't deeply know. And if they don't deeply know the residents, then the stop and watch form is fairly useless. Because in order to prevent an unnecessary rehospitalization, staff have to deeply know the residents in order to pick up on the subtle clinical changes that happen with them. So first who, then what is a chapter and a concept taken from Jim Collins' book, Good to Great. And in this book, Good to Great, they studied 15 organizations that achieved great results for over 15 years. And what they found was they had to devote a whole chapter to their book, to this concept and this congruent concept concept that they found in all of these organizations, and they called it first who, then what. It goes like this. First, you get the wrong people off the bus, then you get the right people on the bus, and then you figure out where to drive the bus. And the good, great leaders in this book figured that out. They lived by 3 simple truths. They said that the key to adapting to change in a changing world is to get the right people on the bus. The right people on the bus don't need to be highly motivated or tightly managed. The right people tend to do the right things and be self-motivated to do the best for the residents and the patients. But they also said if you leave the wrong people on the bus, it doesn't matter where you try to drive the bus because you'll never get to your destination. The good to great leaders had a rigorous process of selection. And what I find throughout my career is that there's many struggling nursing homes that simply do not have a rigorous process of selection. They hire any warm body. And the good to great leaders, they never hired any warm body. And it's really important, I think, that even when unemployment is low and it's very difficult to find staff, you maintain a rigorous process of selection. And to maintain that rigorous process, sometimes you have to change your current process of selection. For me, I always was involved. I was a main screener, if you will, to ensure that whoever even got an interview with our director of nurses was someone that I could trust. So I encourage you to adopt a rigorous process. Observe people in their interactions with residents and patients. Ask people if they're compassionate. Get people talking. You know, you have to use unique questions just to get people talking, to get to know who they actually are. Can you describe a situation when a resident was reluctant to take a shower? How did you handle that? These are the types of questions that get people talking, that allow you to quickly get to know who they are and what their priorities are. I like to try to hire people with self-esteem. And the self-esteem question that I like to use is, what do you like to do with your free time? It sounds like a simple question, but that answer can tell you a lot about this person's self-esteem. Do they have the ability to communicate and learn? And I never hired anyone who didn't smile at me at least 5 times in my interactions with them. Don't hire grumpy people and expect that they'll smile once you hire them. Hire people for their character traits. Then they'll fit into your organization as you need be. Have high standards and express those high standards. Ask the right questions, open-ended, behavior-based. For the higher performers, simply ask to see their last performance evaluation. Most have an evaluation from a previous job, and if they're willing to go and get it and show it to you, that's a clear indicator that this person can be trusted, they're reliable, and they're showing you basically how the previous manager evaluated their performance. And please don't forget to watch the individual throughout your organization, monitor their interactions with people, prompt those interactions, and see whether or not other staff recognize them so that you can circle back to those staff and ask, have you ever worked with them? Should we hire them? Those could be the best reference checks that you get. The godfather of the quality improvement movement, W. Edwards Deming, said that quality of the results is a function of quality in the process. And the essential ingredients in that process are you, the leaders, and your people. And while Deming gets a lot of credit for strict QI and metrics, he also said that you can't improve complex interdependent systems and processes of care until you can progressively improve those complex interdependent interpersonal relationships within the system. And a series congruent with the theory of relational coordination by Joey Battelle at Brandeis University. This is a very simple theory to understand, very complex and difficult to play out and implement in a healthcare organization. It basically goes like this. The effectiveness of care and service in your organization is determined by the quality of communication amongst the staff, which depends on the quality of their relationships. The better the relationships, the better the communication. Relational coordination is highly applicable in our field and specifically in skilled nursing. Why? Because we have a high level of task interdependence. Very rarely do we have an employee completing one task from beginning to end. In our field, our policies and procedures tend to rely and assume, if you will, that people are in relationship and trusting relationships and in communication. Because many of our policies ask staff to cross over and interact with a multidisciplinary team. In addition, there's a lot of uncertainty, and a lot of that uncertainty, of course, is driven by patient need right in the moment. And when you layer on top of that the time constraints that people have, relational coordination, and how people work with one another in order to serve the residents within the moment and keep them safe is critical to the outcomes that we get. What I've noticed is that and many times, even if we have long-term staff, we tend to have silos of relationships and therefore silos of communication. So on the left-hand side, this is what I found in Oakwood, that I had a tight-knit group of staff working in the food service department. I had a bunch of long-term day shift and PM shift CNAs who were a tight group. But they were all really separated and siloed. And I saw it as my role and my job to try to improve the relationships across departments and functions on the left-hand side. Because what was happening on the left-hand side was that our residents were falling through the gaps that you see caused by conflict and discord amongst the groups. On the right-hand side, I'm trying to connect people across departments to essentially create a safety net to prevent my residents from falling through those gaps. Relational coordination has been proven to work and be effective in complex skilled nursing settings. It's significantly associated with enhanced resident quality of life and higher nursing assistant job satisfaction, which leads to retention, lower turnover, and more reliability. And she found that it was highly evident, relational coordination I'm speaking of, in those organizations that have been on the road in implementing person-centered care. So the heart of it for the leaders listening in is that part of your role is to work diligently to try to strengthen connections amongst the staff. Because if you do that, you're likely to retain the top performers and better coordinate the care that the residents are receiving. At Oakland, I had to try to get these people to get along, and I could do that through structuring some fun and interactive events to get them to get out of their silos. In addition, I could structure communication systems to get them talking once I could establish some trust. So in order to enhance staff relations, we rolled out specific events to try to bring people together. The first was just the purchase of a karaoke machine and our first Windsor Idol singing contest amongst the staff with cash prizes. And we structured this such that if you joined a singing group that included different people from different departments, you could win a bigger cash award than if you performed alone. And if you included residents in your singing group, then the amount of cash that you would win would double. So the structure of how we kind of laid out the awards got people to join groups, maybe join with people who they wouldn't normally, all, of course, incentivized by cash, which isn't a bad thing. You know, what we learned from that event was that our staff were not very talented singers, but it was the first event where I saw staff laughing and joking and hugging, and it was an event that no one really could forget. It was a positive impact. And we had Bring Your Kids to Work Day, and this also helps strengthen connections amongst the staff, because when staff, children meet, they tend to, of course, quickly kind of form some bonds, and of course the parents notice that, they start talking, and this is how we started to create some cohesion amongst the staff. The staff in Oakland spoke 21 different first languages, so we had a very diverse staff, and so we began to celebrate what we called Heritage Days, and that would be each group, if you will, from the various countries that they represented, they would come together, they would cook the food from their country, they would dress in their native celebratory dress, and we would have an event where they would share their food, talk about their food, and talk about their heritage. We also had a senior prom for our residents and families and staff with a live band, and the staff also organized a weight loss challenge. All of these were intentional events to try to bring staff closer together with the expected outcome that it would build trust. It would build some trust amongst the staff. It would break down some of those silos, and the end result would be better care and service for the clients that we were charged to serve. Sometimes also we learned that it's not always the environment, it's not always a huge number of staff that are causing other staff to burn out. Sometimes it can be just one person. And if you look at patterns of absenteeism like we did in Oakland, what we found is that we had this one nurse who worked on Station 2 every other weekend, and because she was mean, like Nurse Ratchet, every other weekend, PM shift Station 2, we had a lot of call-offs, a lot of chaos, and a lot of falls. And so clearly, when we kind of inquired with the CNAs why they don't work on Station 2 PM shift when Nurse Ratchet works, they let us know that she's disrespectful, she doesn't treat us well, and as a result, they prefer not to work with her. We ended up having, to get rid of Nurse Ratchet. She was a good clinician. She did excellent documentation after every fall, but essentially she was causing the falls because she was causing absenteeism. So sometimes we just have to reduce turnover and improve retention and improve absenteeism by getting rid of someone who might be causing it. In truth, bad is stronger than good, and some turnover can have a positive effect on turnover, and that's what we learned in Oakland. You have to eliminate the negative. Even if you're struggling to fill vacant positions, you have to eliminate the negative. The fact is that grumpiness and laziness and disrespect are contagious behaviors in the nursing home environment. And so removing people who take away from the positive interdependence that we have, you have to address those people and do it for the good of the whole organization. This was supported by research from Nick Castle, who looked at the relationship between turnover and clinical outcomes of care. And what he found was really that the sweet spot of the interaction between the two is when your turnover rate is about 20%. What you notice here, and you can see at this graph, is that organizations that have less than 5% turnover actually have worse clinical outcomes than nursing homes that have 20% turnover. So what that tells me is that the highest performers in our field have a little bit of turnover because they don't tolerate low performers. They move them out and they bring new people in. Whereas some organizations can have too low of turnover that might be indicative of their inability or unwillingness to get rid of some low performers that they really should get rid of. Some relational coordination tipping points that I experienced in Oakland, it was my job as the administrator to reduce the tension and stress in that organization. And there were a lot of things causing the staff to come in conflict. We didn't have enough high-quality supplies. We didn't have enough linen. We didn't have enough transfer equipment. The composition of our staff was top-heavy with part-time on-call staff without enough full-time staff. And when you have a lot of part-time staff, they tend not to be in relationship with one another. They tend not to be in relationship with the residents and the families, and they certainly don't know the residents or each other very well. Rotating staff assignment takes away from relational coordination. Consistent assignment supports relational coordination. And of course, we enhance relational coordination just through implementing more regular systems and forums of communication, and those were severely lacking in Oakland, and I needed to put those into place. And here's kind of a visual model, if you will, of those steps. First, we had to create some stability and engagement, so the staff had the opportunity, if you will, to notice and deeply know the residents and patients. Then we layer on top of that consistent assignment, and that allows the staff to notice the really subtle clinical changes happening with their residents. Then we add on top of that huddles, which give the frontline caregivers the forum to have true real-time quality improvement closest to the residents and gives them a voice to share what their observations are. And finally, at the top of the pyramid there, you see in these high-performing organizations, they find a way to get the CNA's voice to the care conference meetings so that the entire interdisciplinary team can learn from the CNAs. I want to finish my discussion with you this afternoon by running through some very, I think, effective evidence-based ways for administrators and directors of nurses to really get engaged with their organization and their staff. And I want to talk about how to do rounds throughout your building. I want to talk about community meetings, and I want to talk about notes or written communication to your staff. So the first is rounds. And rounds, I think, have four very specific components. I'm going to go through each one. The first is mood, posture, paradigm. The second is content. The third is timing. And the fourth is follow-up. When it comes to mood, posture, and paradigm, I got to remind you again, maybe the third time in this webinar, that as the leader of your organization, you're never not the leader. You're never not in the spotlight. And you're never not influencing human behavior around you. So you have to keep that in mind as you go out and interact with the staff and residents and the families. So flip that switch. Remind yourself you're in the spotlight. Make eye contact with people because they're looking at you. Be very mindful of your role in praising and building up self-esteem of people, of smiling, of slowing down and lingering and waiting and being present. If you are a positive presence then the more visible you are, the more you linger, the more you'll influence in a positive way. And this last bullet about handing out granola bars, I just have had made a habit throughout my career that, when I do rounds, especially the days before payday, let's say 3 days before payday, I like to hand out fruit and granola bars as I go along and interact with the staff, just making sure that people have something to eat, something that's going to sustain their energy in a very physical job. Content, what do you say and do when you conduct your rounds? Well, again, this is about you triggering higher performance. So what you say and do matters a lot because everyone's listening and everybody's watching. So say things like, I'm really worried about Mr. Jones. Is he the most critically ill in your group today? Is he the most likely to go back to the hospital tonight unless we, do this or that? Say things like, hey, I'm really proud that this unit hasn't experienced a fall in the last 3 weeks. Say things like, thanks for helping with that. That was really nice of you. The residents really love you. I noticed you really care. Thanks for being here today. Hey, I really like working with you. And go and hang out at the time clock at change of shift and thank day shift for their efforts when they're leaving at 3 p.m. and welcome PM shift staff on board as they come in and clock in on time. What do? Answer call lights, hold doors, sit in the break room, sit at the end of a resident's bed and talk to them. Shake hands with people. Carry a leftover food tray back to the kitchen and save a CNA some steps. Move a linen barrel to just the right spot. In other words, do things that facilitate service and care that you're expecting your staff to deliver. Ask good questions. Quick Tutor offers these 5 specific questions to ask when you make rounds, and these are in sequential order, mind you. To build relationships, ask a question like, hey, how are your beautiful kids doing? To focus on the positive, ask a PM charge nurse, hey, what's going well so far on your shift? To try to create a positive feedback loop, ask if there's coworkers or anybody who's gone beyond the call of duty for you today. And when they offer a name of a specific person or caregiver that they work with, make sure to find that person and pass on that compliment. Ask, is there anything we can do better? Is there anything frustrating you today? Do you have the tools and equipment to do your job? You see, what Studer's saying here is that when you do rounds, don't just go up to the nursing station and say, hey, how's it going? Oftentimes you're going to get the staff who will say, just fine, Mr. Administrator, thank you. You have to ask these specific types of questions. So I could say, hey, how's it going? They say, fine. My next question will be, really? Is there anything frustrating you today? Well, yes, Mr. David. Our fax machine's been broken for 2 days. The pharmacy can't get in touch with us. We have to go over to Station 3 to fax anything. It's a real pain in the butt. Okay, now I have something. Now there's something that I can help you with to facilitate the care that you're trying to give. You see, what I've learned is that there's not a lot of administrators who are mean and callous people, but there are some that unintentionally demotivate their staff because they ignore them. Please don't be one of those. Notice people. People want to be noticed. Every one of your employees has a sign on their forehead that says, know me, care about me, and then you can focus me. And that is in sequential order as well. The timing of your rounds, well, the bottom line is that in the highest performing nursing homes, the administrator, the director of nurses, the director of maintenance, they all do rounds before the morning stand-up meeting. They always come in with deep knowledge already about what's going on in the organization. But then they keep doing rounds. They do rounds at lunch, and they're highly visible. They do rounds at shift change, and they're highly visible. They do last rounds before they leave for the day. They pop in on weekends, and they come in on nights. Again, a leader's presence can have a very strong impact on how people behave, and the more present you are, the more likely you'll have a good impact. And then, of course, follow up. Don't carry a cell phone with you if you can avoid it. Take notes as you're talking to people. Listen intently after you ask good questions. People are going to give you a lot of information. Make sure you're writing it down and getting back to people who made requests. The drivers of staff engagement, of course, we've heard over and over again from my interview. Every year they come out with basically the same information and say, based on all our staff engagement surveys, we know that the top drivers of staff engagement are the perception of whether or not the leadership team cares about the staff, the perception of whether or not the leadership team listens to the staff, and the perception of whether or not they care about our stress and are working to reduce our stress. Employee engagement is about trying to trigger a greater discretionary effort, if you will. That's not in people's job descriptions, but it's this discretionary extra effort is what's necessary for person-centered care in delivering high clinical outcomes. Employees are engaged when leaders are engaged. So keep yourself engaged and understand your role is to be focused on their relationships and to drive the business through their stability and their commitment to the job. And finally, I want to wrap up by just talking about your community or general staff meetings. What I've learned is that these meetings can be very effective in pushing an organization ahead. I believe you have to share metrics almost like you're presenting to your board of directors, and you have to trust that staff will understand the metrics that you share with them. It's important for staff to understand the interconnection between human resource outcomes, clinical outcomes, and your business results. And you can show them that and show the cause and effect when you show them data. It's important to benchmark and compare and for them to know what the strategic plan is and how they can support the strategic plan to turn a situation around like we had in Oakland. I've learned through the years, too, that the messages that I'm sharing tend to stick with emotion if I can back them with data. But I can't get too heavy with the data. I need to tell a story. Staff love stories. So I can tell a specific story about a resident that's embedded in the data. It tends to really resonate with the staff. I've also learned that staff love predictability. They love to know what's coming down the pike. And so any opportunity that you can give to give staff more predictability around their work setting, they tend to really appreciate that, and it translates into stability. I see myself, and I hope you see yourselves, as the CEOs of optimism in your organization. Your role is to drive optimism and the belief that we can achieve great results. Celebrate positives, recognize top performers, raffle off gift cards when the organization achieves high clinical outcomes. After all, healthcare is a team effort, and so recognizing and raffling off gifts and giving gifts when the team achieves the data and the outcomes we're hoping for is critical so that they understand that you're valuing their efforts of working with one another as part of the team. And then finally, in Oakland, I used one of my community meetings, the whole community meeting, to talk about softer toilet paper. When I first arrived in Oakland, we were purchasing, everything that we were purchasing was the cheapest stuff you could possibly buy, from the trash bags to the paper towels to the hand soap to the toilet paper. And the toilet paper that we were purchasing was literally one step up from a leaf. And so when we purchased 2-ply or softer toilet paper, I called it out and called it out in the community meeting. Hey, everybody, I hope you notice that we're investing in higher quality toilet paper because you deserve it and the residents deserve it. And while no one stood and cheered, they all acknowledged it. And the switch to softer toilet paper was one of 70 changes that we made in this complex organization, but with each one was important, and it allowed us to take a step forward, to deliver some visible results that the staff could see, which got them energized to make the next step forward. And that concludes my comments and my slides, and wow, just in time. So with that, I'll turn it back over to Donna and see if there's any questions that I can answer or address.
Thank you, David. That was really very informative. We had a few challenges presented in our chat box, and I don't know that we have time to address them. So perhaps I'd like to just read them off, and you can share a few thoughts. But I'm thinking that perhaps if our listeners have some questions that you weren't able to address, they could send them to their quality improvement organization, and I could forward them to you so that you could maybe respond in that way. But the two areas of challenge that were chatted in were recruiting quality staff in remote or rural areas, and then dealing with low performers in a labor union environment. Do you have anything to share about that?
Yeah. In both my experiences in Oakland, it was a unionized environment. And, I would have to say that in a unionized environment, you're still the leader of the organization. It's your responsibility. Don't believe you can't make changes just because there's a union. You absolutely can make changes. It is your organization. Don't feel like your hands are tied. Yes, there will be grievances. Yeah, there will. Just let the corporate office know that there will be, but we're moving ahead, and the grievances or the issues that the union brings related to what we're trying to do, we'll deal with it. But we're not going to tolerate a low performer just because they have union representation. That's not my attitude, and it shouldn't be yours. In rural areas, it's a little more challenging, absolutely. I think in rural areas, you're going to have to work harder at retention, of course, and probably have to really invest in turning around employees in order to get better performance from them. But never underestimate the power of culture and environment and its impact on how employees perform. In Oakland, I was shocked that some of our, what I consider really low performers, turned around once we put systems in place, once we started to paint the graffiti, once we got a softer toilet paper. I saw people change. So never underestimate the power of making lots of changes in various areas. And please, understand that could have a really powerful impact on how people perform.
Thank you very much, David. Jennifer, would you please put the evaluation up? I forgot to prompt you to do that, and we're losing most of our participants here. Thank you. I would like to say that the slides are available. They were sent out to your state's quality improvement organization, so you can contact them for the slides, or if you have the flyer with my contact information, Donna Thorson, at the bottom. You can also contact me, but the slides are available. And I'd like to thank all of you for participating today. And David, thank you for the wealth of information that you shared and the reminders of how to be a good leader in our organizations.
Well, thanks, Dawn. I appreciate it. Thanks so much, everybody, for taking time to join the call.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by for your post-conference.